fantastic. Well, great to have such a large group here. And what's nice is that if we have a smaller number of talks, we can really open it up for good conversation and questions. So do not be shy. This is our more casual part, so feel free to put questions in chat or raise hands. And we really want to have a conversation. It's been nice in some of the meetings that I've been in where people have been, or other presentations, really trying to help each other with the work and think about different strategies and stuff. So excited for that to happen here as well. All right, it's slowing down just a little with people coming in, but so let me turn it over. Want to welcome everybody for this track on artificial intelligence and conversational agents, and very excited to first get to hear from Jeremy Harper from Equip Health. So let me turn it over to you to share your screen.
All right, thank you very much. And hello, everyone. Good afternoon, good morning, depending on where you are. Let me share my screen here. But yes, I'm Jeremy. Oh, wrong button there. Sorry about that. I'm the manager of applied data science here at Equip Health. We're an online mental health company specializing in treating all forms of eating disorders. And what I will talk about today is a tool that we built to try to really streamline a non-clinical part of the kind of online mental health disorder process, which is assigning teams of providers to specific patients. My disclosure slide here, I don't have any financial relationships or anything like that to disclose. But kind of just jumping right in. So, one of the really nice things about providing mental health care online these days relative to even kind of 10 years ago, I was a clinician in my kind of past life, is that there's this ability for us to reach a huge number of folks who need help. Well, that's nice. It does come with a lot of operational problems, such as finding out what provider or team of providers is the best for a given patient, given their diagnosis, where they live, that kind of thing. And as we at Equip scaled as a company, this became a huge bottleneck to actually getting patients' families in the virtual door to start to go on their journey to help treat their eating disorder. So what my team did on the data science side was develop and really implement this automated tool to find the best care teams for a patient to help them on their treatment journey. So what we did was we essentially developed an entire platform from the bottom up, which took our over 200 licensed providers. Here at Equip, we have care teams of therapists, psychiatrists, medical providers, dietitians, and then a peer and a family mentor. So full wraparound care for a given patient. So it's a full multidisciplinary team, which actually comes with a lot of logistical challenges when trying to assign these care teams to patients. We looked at the data and worked with our internal operations and clinical stakeholders to really identify the salient factors that should go into what's the best patient for a given, or the best care team for a given patient, to really make sure that they have the support and care they need. So things like, does the provider actually have capacity to take on new patients? Those of us who have maybe been clinicians in the past, once your caseload gets above a certain limit, it gets hard to provide the best care to your patients. Things like, we're a virtual company. When you're in person, you can just, go down the hall, hop in and do some case consultation. That gets tricky if you're a virtual company and you're paired with 20 other dietitians. So this idea of having these small pods of care teams or shared patients was a very important one. Things as rote, but as important as license compliance. Is this provider licensed in this state, given the state and local laws around virtual practice? And then things like time zone or factors around the kind of provider that the patient wants. Do you want someone specialized in your diagnosis? Do you want someone of a given gender or with a given lived experience? Those are all important factors that we can actually take into account in our tool. And then what we did was, rather than just automating this completely, because we know that there are some important factors that just require that human touch, we give our operations staff and our patients the best three matches that they can pick from to say, this is the first, second, and third best care team. Which one do you feel like is best for your treatment journey? Just some kind of key results that we have. As we've scaled up with this tool over the past 2.5 years, we, we actually saw an almost 90% reduction in the time from when a patient was onboarding for treatment to when their team was assigned and they could start treatment. So this turnaround time from almost 24 hours to just 3 hours was huge for our patients to actually get in the door. We were able to scale up our volume of patients over 5 times increased from what we were 2.5 years ago without impacting our operational ability to serve our patients. And this allows us to assign care teams in batches of patients in the hundreds in a rolling cadence throughout the week, which really helps to just keep our door open to start the treatment journey for these patients. Our admission staff has actually been overwhelmingly satisfied with this. It might not be the flashiest kind of thing that you can do in mental health care, but it really helps to just allow them to increase those touch points with our patients before treatment and streamline that process. Because starting treatment is a scary thing for a lot of patients and families. It reduces that time that our patients have between contacting us and starting treatment, which is huge for increasing retention and reducing that drop off between initial contact and when they first meet with their therapist or other care team member. And it really just helps us to optimize both our company's workflow and our providers' capacity, allowing them to not worry about, am I going to be overburdened next week by new patients? Our ML models take all that into account and just takes the burden off of their shoulders. So just, a quick wrap-up slide here. This automated provider assignment tool allowed our company to scale to a very strong degree over the last couple of years and allowed us to assign care teams in a more patient-focused way. So taking into account things like the patient preference or even boring stuff like licensing, making sure that the care is delivered the way that it should. And for us, it's actually become a very critical tool. There's, I think, no way we could have scaled as much as we have without a tool like this. So some next steps that our company has looked at, looking at things like patient satisfaction with the teams they're assigned, looking at things such as requested reassignments. Are the matches that we're suggesting actually the best for the patients, or there's something we're not taking into account? But also taking this kind of ML structure, maybe making it into like a conversational agent or a chatbot right in our care delivery program that can fully automate the process for patients as they onboard. But I'll kind of stop there. Thank you for your time, and open to any questions.
Thank you, Jeremy. That's fascinating. I'll give people a chance to add their questions in chat or to raise their hand for me to call on them. I'm happy to start us off. I wonder if you can talk about, for this provider assignment tool, I mean, your results are really amazing, and I'm curious to hear, what in particular do you think is most important in leading to those time savings? 24 to 3 hours is remarkable, right? And if you were to pinpoint the factors that you think are playing the largest role, what would those be, do you think?
Yeah, it's a very good question. And I've worked very closely with our scheduling operations team to try to understand that. Before I joined a few years ago, I was actually our company's first data scientist.
Mm.
A lot of this was done um, with nearly a dozen Google Sheets kind of spread across different people in our company, trying to manually find, does this provider have enough room in their case panel to take new patients? Is it a good time zone match? And really just the manual burden of trying to sift through data by hand. Any of us who
Yeah.
have maybe done some outlier detection or things like that, it's not the most exciting and it's kind of exhausting. So really just as a data-driven company, being able to take that and just simplify it, I think is really where most of the time saving came from. That and
Mm.
the ability of recommending a care team for a few hundred patients at a time versus having to have someone do one at a time throughout the week.
No, that's great. Tina, you had a question.
Thanks, Jeremy. And I apologize if I missed this at the beginning of your talk, but what types of machine learning or AI models are you using? Is this generative AI, classification AI? Are these models supervised where you have kind of that ongoing input where you can say, yes, this was a good match. No, this was not a good match. So what's happening maybe a little bit behind the curtains?
Yeah, no, that's a very good question. It is more of the supervised approach. So we built this a few years ago, sort of before, like AI was really hot on the scene. And when we were surveying kind of what would best meet our company's needs, um, we had a few other ideas like using graph theoretic networks to make these very tightly knit groups of providers based on these different factors. And that actually seemed to be kind of overkill for what our operations staff needed. So
Is
there's this
that kind of like a
balance.
neural net? Sorry to interrupt you. Is that I've never heard that phrase before.
Yeah, it's sort of similar. My background, I actually come from a neuroscience background where, from sort of like a graph theoretic, you can think of it, when you see these graphs of like a social network, for example, they were done kind of 15 to 20 years ago, maybe, where um, you look to see sort of who's closely related to a given person based on different factors like your shared caseload or your licensing, things like that. Really, a lot of that ended up being overkill because it was hard to explain to non-technical staff in our company. And it's not really me doing the assignments. It's having this ability of balancing what works really well and what we think does the best job versus what really fits the company's needs. Now, as we've scaled up, we've thought more of rather than having one or two people as the touch points using this tool, could we actually kind of open it up to our patients and families to personalize their onboarding process,
Mm.
given the constraints of what we know is important for finding the best provider. We would never want a patient to meet with someone who's not licensed in their state, for example. But giving that veneer of personalization through like an AI chatbot to see, um, I'm starting therapy. I've got an idea of who I want as a therapist. Um, Maybe I can talk with the bot at Pruett Health and we can recommend a few of those and then they can choose. I think those are the kind of next steps for us. But when we built this and maintained it over the last couple of years, um, it was really sort of a little too much, I'd say, for some of the ideas we had.
Just following up on that, can you talk a little bit about how you think about sort of generalizability of this tool to different settings and where it would work well and where it wouldn't work well in terms of helping people to make those matches to the teams and stuff?
Yeah, I feel like it works very well if you, um, I think from my experience, working with sort of our clinical and operations stakeholders, what I've learned is that for something like this at a company that's trying to scale, having well-defined rules and having consensus on those um, leads to the best outcomes. And I kind of say that because when we rolled this out initially, me and my team would often get lots of questions about, why was this care team assigned? We don't think maybe this was the best because they used to do it by hand, and really trying to bridge that understanding of taking a manual process and the folks who were experts in it at that time and building that trust in what some people might think of like a black box computer doing their work for them. Really, it's not doing their work for them, it's helping them be more efficient or take the boring stuff out of their day. I think without those kind of stakeholder relationships, it gets a little tricky, especially when you're working in like a mental health field.
I feel like it's a theme across like all the presentations and talks I've been attending today is this kind of like technology plus trust relationship community build. Like it's really bringing those together. That's really leading to some of the most exciting results. Thank you, everybody. Please join me in thanking Jeremy for the fascinating presentation. And I'm excited now to turn it over to Tina if you want to share screen.
Awesome. Thank you so much, Jeremy. I'm going to try to do this as eloquently as you did. And I'm going to ask, can everyone see my screen?
Looks good.
Awesome. Thank you so much. My name is Tina Soma. I use she, her pronouns. I'm a research scientist and clinical implementation consultant over at a company called Listen. Today, I'm going to talk about a study that we ran that was funded by NIAAA. I have the acronym on the other screen so I don't get some of the words confused and then the grant number if anyone's curious about some of the ins and outs that we did. It's also published on clinicaltrials.gov. So we looked at how can we use AI as a training tool. So we leveraged a chatbot simulation for motivational interviewing skill development. We partnered with the Prevention Research Institute. Again, this is our funding source, and just a couple of disclosures. Myself, Roisín, Jordan, Zach, and Mike Tanana, we are all employees of Listen and hold company stake. And then David Rosengren and Rita are both employees of the Prevention Research Institute. So again, we ran both a pilot trial and then a two-arm randomized clinical trial. I'm going to talk about the clinical trial today. We randomized folks both into that training as usual condition and then into our client bot training condition. We assessed for baseline skills. We had a washout. Our client bot condition, they were encouraged to do 20 conversations with this conversational agent, which I'm going to show you on the next slide what it actually looks like. We didn't micromanage whether or not folks actually did 20 conversations. We were also very curious if this is something that people wanted to do. We had some fun complexities in doing this trial, which we can really see on the scope of how AI is developing so quickly. This grant was funded at the middle of 2019. COVID hit. We had to do a lot of adjustments in terms of how to change up some of the protocols and recruitments. And so it was definitely a spicy RCT with COVID being in the middle of that. And so I think part of our future directions, limitations, a lot of that is going to be impacted by how we had to change some of the original study protocols. And also at a time where not a lot of folks were really interested in AI or much more skeptical about AI. I think all of that contextualizes what happened in the RCT. And I wish I could do this RCT now as chatbots and generative AI is really coming more into play. I'm really excited to see how the differences would be between the study that we did in 2020 versus what is coming out now in 2025. So this is our little bot. So essentially we had folks log in, they could have different types of conversations. I'm going to back up a little bit so y'all can see. They could practice open questions, reflections, or affirmations, which are core core components of motivational interviewing. They could see how they're doing in terms of using skills in motivational interviewing because they're getting direct feedback from the bot on what types of skills they're doing, and then any encouragement or instruction on how to try different types of skills. This is a proprietary generative AI model that we used, and then we created different types of personas for folks to be able to practice. So these are some examples of folks that people using the bot could talk to. We centered on younger adolescents. Initially, some of these personas were built in conjunction with an organization called Covenant House in New York City that serves unhoused youth. And these populations seem to fit really well for also some of the work that the Prevention Research Institute is doing. Our participants really varied across the board, from folks who were doing DUI classes to folks who are doing motivational interviewing with people with substance use issues every day. So Prevention Research Institute really works with a full variety of individuals. So once folks were in the system, they could click onto a persona that they wanted to practice with, and then they could just start typing. So you know a little bit about who Bo is. We can type, "Hey Bo, how's it going today?" Once we send that conversation, we get a response that is part of that generative AI model. And then we get a little bit of feedback on, okay, what do we want to do in this conversation? I'm in the general practice part, so I'm going to get information about both about open questions, about reflections, and then also about practicing affirmations. So I get a little bit of feedback here. This is what an open question is. They invite longer responses from a client, whereas closed questions can be answered in a few words. So we might take that information and then try an open question, try a reflection, try an affirmation. So from our initial usability results, we use the system usability scale, and then we use 3 scales that were developed by Wiener and colleagues: the AIM, the IAM, and the FIM. Participants who were in this trial generally found ClientBot to be usable, a scale of 66.6 out of 100. The feedback that we got from some of the pilot interviews that we did were that the bot sometimes says really random or strange things. And so we tried to encourage folks, either in our onboarding or trainings, if the bot is saying some strange things, think about clients who say things that kind of come out of left field, or think about, you know, how do you emotionally deal with someone who says something that is off-putting or just a little bit odd? How do you respond with that with maybe an open question or reflection, or maybe trying to affirm and come back to a previous conversation that you're having, or try to keep them on track? Generally, folks found it to be acceptable, appropriate, and then the most exciting was feasible, that this would be a great way to continue practicing my skills, get feedback about how I'm doing motivational interviewing, and then be able to take that into the community with folks that I'm serving. Our initial results did not tell me a lot, which I find to be really awesome, which means that for me, kind of digging in and really Jeremy, I really wish I was a hard data scientist. I am trained as a counseling psychologist. I've done research and practice. And so I think this type of analysis is really going to test my skills in terms of missing data, looking for moderators. I've been learning a lot at this particular conference in terms of what do we think of as time in training when we're thinking about generative AI, when we're thinking about chatbots. Does simply being on a platform, are we somehow osmosising the things that we're supposed to be learning, which we know probably is not happening? And so how do we gauge how much folks are engaging? Is it the length of a conversation? Is it the amount of clicking? Is it if they have a conversation but they spend 10 minutes in one conversation, maybe they're formulating different skills versus spending 5 minutes in another conversation, but there's more talk turns. And so thinking about what that dose of training is and how does that impact the level of MI skills, and then also how is that informed by prior MI skills, how much they're using it in the community. If they say, I have no MI skills, I'm just teaching people through DUI classes, how does that differentiate between someone who already has a lot of MI skills and uses it every day? Perhaps our MI training isn't having a huge impact. So I was hoping to get a lot of information from this conference in terms of how we're thinking about different types of analyses for looking at the impact of chatbots on training. And again, it's so exciting. And I have probably an existential crisis every other day with the amount of papers that are coming out on how quickly a lot of this technology is moving. And I almost feel like this study, even though it's only a couple years old and we only wrapped up in December, already feels out of date, which is really wild to think about. So I saw some questions pop up in the chat, and I can. Bethany, do you want me to go through these? Do you want to moderate questions? How would you like to do that?
Sure, I'm happy to moderate. And let me just double check that so I know how much time we have, because I think there's a million questions we can chat about here. So let me just first check, do we have speakers from the other two talks that I mentioned, or do we have a little more time here? Okay. Obviously, send me a note if they were able to join. So fantastic talk, Tina. Thank you so much. I think one of the first pieces that came up in the chat was trying to understand better, like the range of folks that this training would be for. So like what level of proficiency or understanding of MI would you need in advance? Is it for non-specialist providers or only well-trained providers? Can you talk a little bit about who this is for?
Yeah, really, we would hope to hit the gambit of folks who have used motivational interviewing or who are interested in using motivational interviewing. Thinking about the appropriateness or sort of depth of training for folks who have done long foundational theory classes about motivational interviewing. Maybe they've had some sessions coded by experts. They're looking for how do the complexities of my softening sustain talk and pulling and change talk, how does that impact my client outcomes? This is not the training for you. This is probably the training on I've been doing MI for a while and I maybe just need a little bit of a boost on, do I talk a lot in my sessions? And are my responses really long? And even as I'm typing them, I'm like, whoa, this is quite a long response that I have. How do I bring that back and make them shorter? So those kinds of folks who've been using MI for a while maybe need more of a refresher. And then for folks also just beginning peer supports, beginning therapists, folks in training who are like, I'm nervous about sitting in front of another person and I'm responsible, I guess, for maybe making them feel better, or maybe that's my job, or I don't know if that's my job. Maybe I'm just supposed to listen. That this training can be really great for those kinds of folks to be able to just try some things and get the jitters out in a really low stakes environment where if they ask a weird question, it's okay because it's a machine learning model. It's not a person, and we can have a reflective moment, run it back, we can try it again.
No, that's awesome. Dr. Suri, you had a question.
Yeah, you can call me Tanu, but thank you. You might have answered my question already, but this sounds like it might be really useful for those folks who may be in advanced training during their educational journey already. So graduate students who are like
Mhm.
getting ready to work with clients or maybe have their first feel out with clients but are honing their skills. So it'd be really great for like therapists in training, counselors in training, those
Totally.
kinds of folks is what I'm thinking of. This might be really beneficial for to kind of test out some mistakes perhaps.
Oh, totally. Again, I imagine a lot of folks in this room used to be providers. I remember sitting with my first client and having this moment of like, I wonder when this person's therapist is going to come in the room. And then being like, oh, that's me. And I've heard that experience from a lot of different folks and almost not even realizing that, oh, wow, I was really hoping that someone else would take care of this because I feel nervous. And so I think we want to, at least in the training realm, I want our tools to help folks understand confidence and then their competence around treatment so that when they're sitting in the room across from that first person or virtually, that they're like, okay, I know that I'm in here and I'm supposed to be the one providing treatment and I can do that. I feel good about that.
Yeah, thank you.
Yeah.
Jeremy next, and then we have question in the chat, and then we'll turn to Paige.
All right. First, thanks, Tina, for the very interesting talk. Yeah, you mentioned that there were some times when the conversational agent would say some kind of oddball things. I guess, do you have some examples of kind of what those are. We hear about like AI models having hallucinations or giving false information. And then what kind of guardrails did you all put in place, or would you consider putting in place um, if this were to roll out as a training module, say in graduate counseling or clinical psychology programs?
Yeah, totally. And again, this was I'm just thinking too of how quickly generative AI technology, even how our models and different products that we use that are classification and generative AI based, how quickly they advanced. And we couldn't update this model because we're in the middle of a randomized clinical trial, which is, I think, another place where our field needs to think critically about how we do traditional randomized clinical trials. The bot definitely said racist and offensive things, which was highly inappropriate and unacceptable. And so whenever, as much pressure testing as we did, if it ever said something inappropriate, racist or offensive, we had folks please screenshot it, please send it to us. And then we went back and manually suppressed. And that list would just be ongoing as both different users would interact with the bot in different ways, different cultural contexts. Just as history was progressing as well, we're finding that there's different ways that we say things that are really inappropriate. And so we would just have folks send us what's happening with the bot, and then we would do either a manual suppression of those phrases, and then we would do both internal pressure testing, and then we would also send it I think at the time we were using Mechanical Turk to also do some pressure testing of like, please try to break the bot and see what happens with it. And this chatbot was also in the initial paper was from Mike Tanana at the University of Utah. So this came out of some research that he did in 2017, 2018. So there's sort of been like 2 or 3 phases of pressure testing that we did. And then in the RCT, which again, we're still asking for feedback from folks on, what is the bot saying that is inappropriate, uncomfortable, offensive, and we're going to immediately mitigate that. And I kind of went on a tangent, Jeremy. What was the other part of your question?
No, thank you. I think the last part was if you were to, take this and kind of roll it out into formal training programs, um, are there certain guardrails you would put in place, or how would you enact those? Just, I'm thinking of when I was a junior clinician, there are complex, difficult cases and situations, but you kind of slowly work toward those.
Mm-hmm.
So how would you, I guess, sort of, yeah, put some guardrails around these AI chatbots to avoid things like highly offensive responses if it's not part of that training?
Mm-hmm. I mean, I'll share sort of a funny anecdote that brought us to why this was created as client bot. We tried to make a therapy bot in like 2017, 2018, and it would say things to the client like, I love you, and do you want to get a drink with me? And we're like, oh no, therapists are not allowed to say this
One
to
or two
clients.
boundary issues.
We are running into a lot of boundary issues. However, clients say inappropriate or strange things to therapists sometimes, often, depending on what types of folks that you're working with, if they're needing support with emotion regulation or impulse control, or they're experiencing schizophrenia or psychosis. And so we thought, well, let's make this into a client chatbot and then turn it into a training tool. So just an anecdote to say, I think you're totally right that the scaffolding in terms of development level for clinicians is super important. I would say another big ethos that I hear at this conference is human in the loop is really important. And so having supervisors, other folks who are training to help support beginning clinicians to say, let's start using this and see how we're doing through it. How is it making you feel? What are your initial reactions to this? Oh, this felt like a hard and complicated statement to figure out. Let's actually flag that and talk about it. What came up for you? What's happening for you emotionally? How are you getting activated in this moment? How would you deal with this if that was a client? Or again, these are generative AI models from 2020. It would say things like, I really want a cookie right now. And you're like, okay, well, that's not exactly therapeutic content. So then it's just the practicing of, I appreciate you sharing that with me. Let's go back to what you said before to get that muscle memory of how do we, in the situation where a client says something where they're maybe trying to avoid or divert, how do we then bring it back to the content that we're trying to talk about? And how do we do that in a practice and artful way? So if this were to be, if we were to take this to market, or for any other, I would like chatbots that are out there to help folks do training. I mean, I think all I can emphasize is human in the loop is super important. And then for us as the providers or purchasers or consumers to know what we're getting into and ask exactly the questions that you are, Jeremy, of like, what are the safeguards? What could go wrong? How do we need to put this into our curriculum? What do we need to do to make this feel safer? And then how do we deal with it when it says something strange or bizarre?
Fantastic. I want to shift to some of the great questions coming in chat, and then Paige, you'll be next. So there's a question here. As a clinician, I wonder if your team is looking at any bias measures, such as the medical condition regard scale, to assess if other clinician-derived factors may impact MI skill development. So not an AI question, but just sort of an MI skill development focus question.
I do not know the medical condition regard scale, and I'm going to look that up as soon as this talk is done. So thank you for asking that question. I also was immediately thinking AI bias. And so listen, as a company for our other products where we provide motivational interviewing fidelity, we do an AI bias assessment. It's on our website. We would do the same if this particular product was deployed into the community. But I don't know what that scale is, so I'm excited to look it up.
So my guess is part of what's being asked here are things like if there are clinicians who might hold certain biases or stigmatizing attitudes to certain diagnoses. So for example, a client with, patients with borderline personality disorder are often stigmatized against, and there can be, like certain groups where we know there's high levels of stigma,
Yeah.
even from the provider perspective.
I was the person who asked the question, and yes, that's exactly it. I hope it's okay. I'm jumping in.
No, please.
I don't have it memorized per se, but the scale even asks things like, am I willing to give this client extra time, for example? So it's a really interesting way of measuring bias, and it even is substratified by substance use disorder, for example. The one other scale, if you guys are looking at this, I wonder if it would be interesting, are burnout scales for clinicians. This could potentially impact anything.
Yeah, we didn't include a measure of burnout, I don't believe, in this particular study, but in subsequent clinical trials we've run, we've included measures of burnout. I don't know if you have read any of Jesse Owens or Matteo Bugatti's papers. They do a lot with burnout, and they're going to be looking at burnout and if whether or not it's mitigated by different digital tools. So we're working with them and hoping to keep incorporating things like burnout and then into future studies, which I think will be fabulous. And I'm writing down this scale. I think that that's a wonderful measure to also think about how that, especially for folks who are seeking substance use treatment, or you're sitting in front of a room of folks who have DUIs, and what preconceived notions do you have of that room of people, and how does that kind of get incorporated into the training? Or how do we talk as we're onboarding folks if they want this kind of product to say, this is an important thing to consider. Is that a module in the training? So I love all of these ideas.
No, this is fantastic. Paige, thank you for being so patient. Let me turn to you.
Oh,
hi, Dr. Soma. I always appreciate the opportunity to hear you talk about your work. I have a couple of questions. One is maybe a little unfair to ask of you, but I imagine there are other people who have thoughts about it. It's who is ultimately responsible for what a chatbot says? And the immediate precipitant for this question is I was listening to a hepatologist yesterday who's building an AI model for doing pre-screening. And one of the pre-screens is like for suicidal ideation, and then that's going to go to someone in their hospital organization reporting suicidality. And, So that was the immediate precipitant, but
Mhm.
who is responsible for what a chatbot says? And does it depend on how the chatbot is trained, if it's rules-based or generative and so forth?
Thanks, Paige. That's an awesome question. And so good to see you again. I got to meet Paige in person at ABCT in November. So good to see you again. I think that's a fabulous question that really brings me back to thinking a lot about accountability. I think a lot of what I read about AI too gets us into hype mode of we want to be really excited about it. It's going to change the world. It's going to ruin the world. It's going to do all these things to the world. And for folks to sort of sit and say, well, whoa, we don't know. We have no control. I think we have a lot of control. And the models that we're building is both within, a lot of it is within our control and what data we're feeding it. A quote I was thinking of from one of the speakers, and I'm just going to pull up his name. It was Cesar Escobar Vieira, who was talking about kind of cultural biases and what kinds of disparities we're seeing. The data is also showing us what disparities are there. And then it's up to us as scientists, as data scientists, to then go back into the data and to say, okay, what biases are we finding? What disparities are we increasing by having this model run? What data do we need to redo or recode, or how do we need to think about this particular diagnosis, how we frame this particular question? Again, a lot of the other things that we do at Listen are based on classification AI models. And so I always tell people our models are only as good as the coding systems and then the human coding teams who we hire and train by humans to then code the data. And if those human coders, human annotators, can't come to agreement on a different concept or construct, or if they're coding it in a way that is racially biased, that does hold different types of bias or different types of preconceived notions about data, about people, that is going to come out in the data. And then it's our responsibility to run things like bias models, to do the pressure testing, as Jeremy was saying, to make safeguards and guardrails of who is this going to be deployed to. And it keeps me up at night for some things of like, what is the worst case scenario that could happen? And I want to be prepared for that. I just got some tingles just thinking about, providing people with suicide prevention and risk assessment information. That's something that we also do at Listen, where we're labeling things that have already happened. And we want to make sure the accuracy of that is as good, if not better, than it's as good as the human team, and it's consistent with our human team, that our constructs are reliable. That stuff keeps me up at night. That goes back to the existential crises of 2025. So I think I feel responsible, and I do want to take responsibility, and I want to be accountable to that for folks who are using AI. I don't want to send something into the world and say, good luck, I think it's okay, because I don't think I'd be able to sleep at night. I might also, Jeremy, I'm curious too, what your response to this question might be on who's responsible for this and who's accountable.
Yeah, it's a very good question, and I think a very tricky one. In some sense, like an industry company, I would say the responsibility, a lot of it would lie on whoever's building the AI tool or building a product that uses the AI tool to both have safeguards in place. For example, there are ways to evaluate like the output of a generative AI model for things like factual accuracy. There are some softwares out there that will listen in on a session and write your clinical notes for you. Now that seems really good. Like, I've written clinical notes before. It's exhausting if you have a lot of patients, but relying on something like that to accurately document what would go in that clinical note, I think it's a little precarious. Like, I'd be a little worried about it. So you'd want to have some tools in place that would essentially take the output of that and make sure it's accurate. Whether that be a human, which would be the ideal, but at a scalability level, there are some open source software packages that can evaluate AI outputs, kind of like wraparound guardrails to say if it doesn't meet our threshold that we define, go back and try again following these rules, kind of like a reinforcement learning process. Or just don't show anything to the user and you have to write your own note. So I think it's both whoever is building it to monitor and make sure it's actually working well over time, but then also the end user. If the provider is using it, really they should know and should maybe have some education on that these things aren't infallible. They make mistakes, just like people. AI models are very flashy. They can do a lot of things very well. They don't do some things very well. So I think it's a balance. I feel like there's not a good single answer to it, but it really takes, it's a joint effort, I would say. But I think it's definitely one that our field and the mental health field in general should be having over the next couple of years, just given the proliferation around AI, what it can do, and maybe also the pressure of using AI at companies or in practice or in training.
I'm gonna thank you so much. I know we just have 1 minute or so left at this point. So I just wanted to allow everybody to join in here. There was a question put into the chat about knowledge about other bots that are doing training in modalities beyond motivational interviewing. And so feel free to call out or add to chat about sort of your knowledge about other exciting models in that space. And while people are doing that, let me just do a huge thank you to Jeremy and Tina for just sharing such fascinating work. And honestly, I enjoyed the Q&A so much just to hear everybody's thoughts and questions. And it's such important work and challenging work. So really appreciate everybody's insights. And for those who are asking the question, we've got some answers coming into chat for you there about some opportunities to follow up. Thanks, Paige, for sharing that. Thanks, Tina. Fantastic. Well, time has flown by here. It is 4:50. Again, thank you so much, everybody, for joining, and we will see you at the upcoming SIG events. I know Paige is moderating for the student and trainee SIG, so hope to see many of you there. Thanks, everyone.